healthcare.
Here in front of you.
Yeah, just like the caution the use of comparing international stats on, infant mortality rates or whatever you're going to choose, because we have very different surveillance systems. And for instance, that a lot of developing countries, they don't have aggressive pursuit of preemies, for example. They don't count if you're not under a certain weight and you don't thrive. It's not included in their official reports. Also, not only that, a lot of the maternal child care doesn't happen in the hospital, so we don't really know the actual numbers. So when we start comparing U.S. rates against worldwide rates, the data is really suspect. And so I want to be careful when we talk about that. We're doing really, I think we can improve here, but we're certainly not in the same, class as Eastern Europe and most of Africa and Central America. We're very different. So the idea that somehow we're at the bottom of the pack is not really accurate. Also, Cuba has a lot of political incentives to distort their healthcare data, because that's part of their claim that they have a society that's more careful and inclusive of everybody. But there is a tendency there. The UN has also acknowledged this, that there is an issue with the actual data. So I just want to get the sensibility out there that it's not as clear cut as it first seems.
I think your point is well taken, and but I think one of the real lessons learned can be from comparing ourselves to like countries.
Sure, which is a really small pile.
To France and England.
Even France and England, there's some discrepancies as far as how they record their data, and there's categorization differences also. So obviously we're not the best, but we're certainly not on the worst side of the pile. I always ask people, would you rather be giving birth in a hospital in the poorest section, the poorest hospital in the United States, or the best hospital in Dhaka? Usually it's the United States.
Thank you. Question here in front.
Right.
I was wondering on the international pathology services, you say you daily doing diagnosis and other things. How does that get funded?
The funding for international pathology services comes from several different places. Bronson Hospital, where I work, supports what I'm doing in that they allow the technologists that work with me to do this on their own time after Bronson's work is done. And part of the cost of that, they're helping sort of underwrite, and what they don't cover, because it's a nonprofit organization, I have donors and outside support that sort of covers that. I do have to charge a small fee for each of the biopsy cases that I look at, but here again, it's interesting. If you go to your dermatologist and have a mole shaved off here and send it to your pathologist here in town, our bill is probably going to be about $200 to you or your insurance company, whereas my bill to the hospitals in the international scene is $5. So there's so much overhead and whatnot that we have to take care of here that I don't have to do. So between Bronson, my outside support, and small charge, that's how things are handled.
Yes, ma'am.
There seems to be a theme amongst everyone on the panel about the importance of community and structure in changing poverty and changing healthcare here in Kalamazoo. And so my question is kind of twofold. How, and maybe Denise, you can answer this, because you said there was mandatory community service in the refugee camps where you were at. What effect did that have on the way that the community came together and was able to understand better the needs of people around them? How does that translate to us here in Kalamazoo? And what can we do as future providers? What will our role be in that within the community here in Kalamazoo?
Well, that's, kind of interesting. I can tell you some negative and positives about some of that. The community service that was required, and often we would have in my class, we might have a 16-year-old, really gnarly teenager who just did not want to be there. Didn't want to learn, but he was required by his community because they couldn't find anyone else maybe in their block to represent who could read. So they had to read to be able to be there. So, required community service has definite issues with it because it's not always a good match with what they're required to do. So that's one thing. The other part of it, though, that I see is that I think that in order for a lot of programs to be successful, you have to have a reciprocal benefit. Okay, so meaning that the person doing the service has to get benefit from it as well as the person receiving the service. And so the most successful health promoters that I taught were ones who really, really wanted to do it because they loved medicine. They liked what they got from it. The international workers that I saw working there, the ones that were the most successful were the ones who were doing it because their motivations weren't only just to help people. It was also, this is an adventure. I'm having a lot of fun doing this, or I'm getting a lot from it. So that reciprocal benefit, I think, is something that you as healthcare providers, when you go out into your communities to work, need to recognize that it's got to be a good match. So what you're doing, you have to enjoy. You have to like it, and then the rest of it kind of snaps into place. Does that answer your question?
Yes, Don.
I think his point's good, but I think the question is, how can the richest country in the world allow so many of its citizens have such poor access to basic health care? I mean, I've lived in Nicaragua for a while, and they still have the resources. But this country has gross national product 4 times as high as any other country in the world. And we have our people in this country that you see every day, Denise and Carmen, that are living in terrible kinds of situations that embarrass us. And I think the question for us, as educated people and as professionals, is what are we going to do in the face of the assault on poor people that is happening in this country right now? What's going to be our response? Are we going to do more studies? Or are we going to get out there and do something about trying to change it? Oh, well,
I just asked what that would be.
there will be, our congressman is doing a tour next week of this area, and he will be at Portage City Hall next Tuesday morning at 10. He'll be at Kalamazoo City Hall next Tuesday at noon. And I think that would be one step to let him know what we think about that. A week from Friday, on the 25th, there will be a rally at Bronson Park that's being sponsored by the union, social service providers, seniors, people that are involved with the schools. It'll be from noon until 1:30. And there are plenty of groups around the country that are organizing to fight for the basic needs of ordinary people, and we can join them.
Can I just interject something before we take another question? We were talking about this yesterday, Carmen and Denise and Richard and I were talking about, what would it take? What do you need at your family health center? One of the things she said was we really need specialty care. That we really have a hard time finding specialists who will provide services at a discounted price for people with no insurance. So when a consult alone, just to send you to a cardiologist, costs $400 or $500 just for the consult without the testing or treatment, it's hard. So, and they only do primary health care, that's all the funding they get. So we thought, wouldn't it be nice if all of the professionals in this county, in Kalamazoo County, by the way, what was that statistic you gave? 750 MDs in this city here. And so if you look at per population, we have tons. There's a lot of doctors in this town. And so why, if they all gave 3 hours of their time, which she tried to do, she'll tell you about this, a dentist, and if they all gave 3 hours of their time, it wouldn't impact their quality of life. They could still make the same basic salary that they need. They could, but if everybody made this commitment to their community to do that, to provide that 3 hours of care, times 750, or 3 hours, you had it nailed, you know? So, but what happened when she tried to recruit people for that?
So to elaborate on that a little bit, I'll quickly talk about the specialty piece and then talk to you about a dental piece that we also provide. So in understanding subspecialty, what we are supported is primary care. So that's once again just going to see your regular family physician. Oftentimes, by the time that patients come to us, or early if we're able to catch it, their conditions are much more exacerbated than what we can ever care for in the regular setting. Meaning they are at the point where we have had people come in, we regularly have codes, and that's when a patient may come in and go into a cardiac arrest. They've been having some tingling in the chest for the past week, they tell us, and just through lack of education, et cetera, by the time they come to the clinic, it's extremely serious. And so, obviously, if they go into cardiac arrest, then we're transferring them to the hospital. But anything prior to that, your next step, typically, as if we were insured people going to see the physician, the next step is that we would refer you to a specialist. So we're going to refer you to a neurologist, a cardiologist, et cetera, depending on what's taking place within your body. Well, we do not employ and we don't have access to specialist physicians. And the majority of specialist physicians are not required to take Medicaid, and they're darn sure not taking uninsured individuals. So there's nothing worse than to tell a patient and do a complete workup, or to tell a parent that absolutely you do your EKG came back this way, you do have some serious heart conditions, but unfortunately we don't have anyone that is willing to accept. Oftentimes there are wait lists, and I think we have to understand, in all fairness, the whole economics of it, because to care for a Medicaid patient or an uninsured patient is very costly. Medicaid does not begin to cover the cost, et cetera, et cetera. So there is an element of business and being able to stay in business from the fairness of the specialist. But on the pure human level, it is very difficult to say, and I'm sorry, of the 750 doctors in our community, you know, the 2 offices that accept, they take 3 a month. And so we've exceeded our 3, and so we're going to try to keep you coming back to the hospital. Keep coming back to the clinic. We're going to try to keep it going until we can get you in. I will be honest, the waits may be 6 months, 5 months, etc. Worst case or best case scenario, and I don't know that I'd say this publicly, but there are times when they would have to present at the emergency room right at that particular time where they need to be admitted, and then they'll see the cardiologist on call, et cetera, because we do have good hospitals here. They're not going to allow people to die. But you have to be at a certain level if we can sustain you in a clinic. So that's the whole subspecialty piece when we talk about. And so we were talking about, we had an issue with dental. Obviously, dental care is extremely difficult, not only in Kalamazoo County, but in any county. Very few, if any, dentists accept Medicaid, as well as uninsured. And if they do, it's a very, very small portion. So we all know there's nothing worse than dental pain. So at the center, we were able to get a wonderful grant, and we opened up 5 dental chairs. And so in doing that, there's a huge need. Once again, we're looking at a 60,000 population. We've got 5 dental chairs, and we were looking at bringing in dentists. So one of the ideas that we had is, how can we get this established? And to recruit a dentist, they're very in demand, and so it was very hard. We had 1 full-time dentist, but she could not begin to dent 60,000 people. And keep in mind, now we're talking about emergency care. We're not even doing preventative care like cleanings and fillings and et cetera. So same thing. By the time patients would come in, we'd get them started on antibiotics, et cetera. By the time they got